I'm Dr. Morin. I'm the director of the bariatric program here. I'm the only bariatric surgeon we have in Kings County. You guys at Downstate do have a bariatric surgeon, but I don't think there's a program there yet. But if you do get a program, some of the stuff that I say here, you will see also in Downstate as well. With me today, I have Katie, Mary Moses. She is our dietitian. You can say hello. And then Pamela LeBron is our physician's assistant who works with the program as well. So I'm just going to give you a quick lecture about bariatric surgery. We only have about a half hour, so I'll try and be quick and just go through some of the most important stuff. So this is the picture of us. You got most of us on our worst day on that picture, so that's okay. And Katie's not in there, but I'm all the way to the left. This is Andrea Skoranek. She is our bariatric coordinator. This is Melissa Hall in there as well. She is our clerk. Dominique, she's our patient navigator. She takes care of all the scheduling of the cases. And Pamela LeBron, all the way to the right, is our PA. So real quickly, the types of patients you'll see in various stages of their weight loss and operations. Patients who qualify for bariatric surgery, the BMI of between 35 and 40, you have to have another comorbidity, such as diabetes, obstructive sleep apnea, HIV. There's a lot of lipodystrophy with the HIV medication, so we do actually operate on a lot of HIV patients. As pseudotumor cerebri, mostly in the adolescents, that's a good indication to operate on these patients. So they actually do very well. There's like over 90% reduction in headaches from pseudotumor cerebri. Fatty liver, non-alcoholic steatohepatitis, hepatosis, and menstrual dysfunction, as well as osteoarthritis. A lot of patients we get transferred to waiting for knee operations. They need to lose 100 pounds before their knee operation, so they get given to us. Any patient with a BMI 40 or above, they can get the operation without any comorbidities. So 40 and above, no comorbidity. Between 30 and 40, they have to have a comorbidity. I have a cutoff of about 450 pounds at this program, just because of the safety of the operation, but we work with the patients to lose weight to around 450 as well. We also do adolescents here as well. So anybody 15 or older with an adolescent, mostly the same criteria between 35 and 40 BMI, but pseudotumor cerebri is one of the bigger criteria, along with diabetes. So the benefits, we'll go through some of the benefits again, but real quickly, you can see, it's not just about losing weight. The whole thing about bariatric surgery is it really improves your overall health pretty dramatically overall. Migraine, pseudotumor, fatty liver, 90% improve, cardiovascular risk disease, 80% improve. Even if you've had a prior heart attack, bariatric surgery will reduce your risk of having a heart attack by 60%. It's actually one of the only surgeries you can do that is not a primary cancer operation, but it will reduce your risk of developing a cancer. And those two cancers are breast cancer and colon cancer. So doing bariatric surgery actually reduces your risk of getting those two types of cancers without operating or doing any other, anything to the primary tumor itself. So that's interesting. And I've also had patients with stress incontinence, bladder dysfunction. We operate on them as soon as they start losing weight. That stress incontinence goes away. But one of our biggest claim to fame for bariatric surgery, is what we're really known for, is our reduction in type 2 diabetes, both insulin dependent and non-insulin dependent. Insulin dependent diabetics have a really dramatic response where, because we reduce the amount of PO intake they can take right from the operating room, most patients before they leave the hospital are off their injectable insulin. The rest maybe a week or two. Their resting AM glucose, when they take their blood sugar in the morning, every morning, it goes from, whatever it was, 230, 180, 300, which is their average, or whatever it was in the morning. And it drops it right down between 90 and 120 within a week or two, which is pretty dramatic, and patients are kind of blown away. And this is before they even lose any weight at all, and especially if they listen well to the dietary instructions, because the PO intake is reduced dramatically from, I don't know how much these patients are eating, but it's probably anywhere from like 3,000 calories to 4,000 calories a day. And we're dropping it down, especially in the immediate post-op period, probably to like 500-600 calories a day, maybe, and that gradually increases back to a little bit more over time. But when you drop this calorie intake, their ability to have a calorie intake, it really has a dramatic effect. There's two types of surgeries that are done mostly in the United States, and the two types that I do mostly here. The vertical sleeve gastrectomy is a very popular surgery. And basically what this is, we go in, I do all my surgeries robotically, but we go in and we take out about 80% of the stomach. And you can see from the diagram here, we just use a circular stapler. I devascularize the greater curve, and I use a circular stapler, and we have a tube inside the stomach, a bougie, and it sizes the stomach to 36 French is what I use. And then we just staple along the edge of the bougie, makes a very small pouch, really like the size of a small banana. Some people call it banana stomach. It's pretty good. It moves about 50 to 60% of your excess body weight. And then with following the diet and protocols and exercise, hopefully patients will lose more. It's a quick operation. My average operative time is about 35 minutes. Not including putting the patient to sleep and waking them up. So, the whole thing takes about an hour. Hospital stay, 90% of patients stay one night and then they go home the next day. And after the operation, patients are up and walking, drinking water, even a couple hours after. So it's really pretty quite a dramatic recovery. The only thing is it's non-reversible. You can't put the stomach back, obviously. And but there's no intestinal bypass. So it's sort of a non-reversible, but the less invasive of the two. The gastric bypass is the other surgery we do. I make the stomach into a small pouch, and then I split the small intestines about 150 centimeters from distal to the fourth portion of the duodenum, and I bring up a limb called the roux limb, and then I connect the biliopancreatic limb down another 150 centimeters. So you don't really absorb anything. And I make the stomach a small pouch. So you eat a small amount of food, so it's restrictive, and then it's also malabsorption. So you don't absorb much nutrients or any really until the bile acids mix 150 centimeters down that small intestine. So patients, the food they eat goes straight into the small intestines, and they don't absorb anything until everything goes into what we call the common channel, which is where the bile acids mix. It's a pretty good, solid 60% weight loss in 1 year. This weight loss is better than the sleeve, and it's quicker. The operative time is a little longer. It's usually about 2-hour operation, and it's a little more complex. So there's 2 anastomosis. So and this is the operation where you get more of your complications, which you guys will see in the emergency room mostly. And the hospital stay is 1 to 2 nights. So. Just real quickly, I talked a lot about it. I just wanted to go through this. I won't take much time on it. But the Mayo Clinic, they took 150 patients when this is back in 2014, and they wanted to see how, everybody, loved bariatric surgery, but they wanted to see how good it actually works. They took 150 patients. They did 50 gastric sleeve, 50 bypass, and 50 medical management for type 2 diabetes. And so we can see at 1 year, the change in A1C for the bypass and the sleeve, average 9.3, it went down to 6.4, 6.6 in 1 year, which is exactly what we see here. And for invasive medical therapy alone, it only went down to 7.5. Same thing in plasma changing of your fasting plasma glucose, where the patient checks in the morning. So like I said, the average for the sleeve and the bypass was higher in the beginning, but we see at 1 year, the average is 99 and 97 for a sleeve and bypass. So we see these numbers all the time. And even over a year, they do very well. You can see even at 3 months, they're only at, the average is 109, and it gets better and better as they go. Average number of diabetes medication, the bypass and the sleeve are less than 1, which is what we usually see here too as well. Patients come off their medications relatively quickly. And then change in BMI at 1 year, obviously the sleeve and the bypass do great. So they took it at 3 years. So that was 2011. They took it at 3 years and they looked at the same outcomes. The short story is that, patients do regain a little bit of weight. They lose a lot of weight and then they regain a little bit and then their weight levels off. So what we see is pretty much what we expect. The gastric bypass is a little bit better with A1C is 6.7 at 3 years. And then change in A1C So same thing, change in A1C for patients, and they split it by BMI. The greater the BMI, actually the greater change in A1C, which is pretty great. Patients lose a lot of weight. They have, patients who are big and they lose a lot of weight, their A1C changes quite dramatically. And then same thing, their diabetic medication, gastric bypass is still average less than 1 diabetic medication. And then they did it again at 5 years. And you can see same thing. So most of these patients did pretty well. So hemoglobin A1C of less than or equal to 6 is one of their cutoffs in the study. And we see the gastric bypass still had 28% of these patients less than or equal to 6, whereas medical therapy only had 2 patients, which is 5%. So they're doing pretty good, and we can look through the rest of this stuff. But I want to talk more about the complications. So I mean, a short story. This is published in New England Journal of Medicine. So it's one of the bigger studies that shows how effective it is. Since then, there's been lots of similar studies published in multiple journals about the effects of bariatric surgery. So I just wanted to talk a little bit about the diet progression. So when you physicians see bariatric patients in the emergency room, it's good to understand what stage of the operation they are and what diet they're on. So do you want to say something, Katie? Or? Yeah, I have Katie, the dietitian. So we do the operation, and then the first couple of days they're basically just on some water and some broth. But then, yes, go ahead, Katie.
Yeah, so for before they're discharged after the surgery, they're going to be on a clear liquid diet, but this is a bariatric stage 1. This diet doesn't include any added sugars, no juice, no carbonation, and no straws. So no ginger ale for these patients because air can build up and cause them to lose more fluid. So we want to make sure that they're avoiding all carbonation and any added sugars because that can cause stomach upset that soon after surgery. Bariatric stage 2, this is the diet that they go home on. They follow this stage for 2 weeks. So if a patient comes to the ED 2 weeks post-op, it's likely that they're going to be on a full liquid diet, mostly drinking sugar-free clear liquids and protein shakes.
So for example, patient, protein shake has like what, 150 calories about?
Around under 200 calories,
yeah.
20 to 30 grams of protein and less than 10 grams of sugar. There is a Ensure product that's being added to the formulary in New York City Health and Hospitals. So there will be a bariatric option being added soon. But regular supplements like regular Ensure, Glucerna, the ones for kidney disease, those aren't recommended for bariatric patients because they're too high in fat and sugar. I
just want to say one thing. Yeah, so some of the patients, like some patients can get in immediately the first week. They can get in, 2 protein shakes a day. Some patients can only get 1 protein shake and maybe a little bit of yogurt. So think about, they're only getting, 300 to 500 calories those first few weeks. So, some patients might experience a little bit of malaise. But they're going from eating 3,000 plus calories a day to, 500 or less those first couple of weeks. So there is, usually some feelings of tiredness, and they're sort of getting used to their new life. So,
yeah. So after 2 weeks post-op, they then are on a pureed diet for 2 weeks. So this is the bariatric stage 3 diet. So this is very soft, sort of like pureed, like protein foods, really focusing in on those protein foods, transitioning from the protein shakes to the soft foods, and then some pureed fruit and vegetables. So if they're less than 1 month post-op or they're not able to tolerate soft foods when they come in, then putting them on the bariatric stage 3. Bariatric stage 4 is the soft diet. This is anyone that's more than 1 month post-operative. This diet consists of like 2 to 4 ounces of protein, about a half a cup of vegetables, and then 0 to 2 tablespoons of starchy foods. But the most important thing, especially whenever they're coming into the emergency department, is hydration. Is that the next slide?
Let's see. No. Yeah, so we're going to talk about, we can talk about hydration, minor complications. We'll talk about minor and then major complications. Hydration, like Katie's talking about, they're like, for what I always tell patients is when you wake up in the morning now, you can drink a glass of water, hydrate yourself. After bariatric surgery, when you wake up in the morning, you can't do that anymore, especially if you want to eat some food. you know, you have a little glass of water and, you know, maybe a little bit of food. So your hydration, these patients have to be drinking, you know, every 20 minutes, every half hour throughout the day to keep themselves hydrated, especially for their overnight sleep. And they got to start again in the morning. And they're often full when they drink and they have to wait to eat. So they have to sort of time it. So we have patients who are very good at it, but also patients who are not very good at it. So there's some adjustments. So patients come in, you know, dehydrated, feeling bad. They get nauseous because they're dehydrated. They're losing a lot of weight. They have some malaise. Their calorie intake is down. So you'll get like a very mixed picture of, you know, these patients just feeling bad. You don't really know what's wrong. But usually we just start, you know, if they're pretty immediate post-op, hydration is one of the main things.
Yeah, their goal is to get at least 8 cups of fluid each day. They can tolerate about 1 ounce of fluid like every 15 minutes. And they need to separate eating and drinking by 30 minutes. If they eat and drink at the same time, that could be the cause of any like hyperemesis that you see these patients present with, is because they're not separating eating and drinking.
Yeah. So some of the minor complications we see post-operatively are what we just talked about: dehydration. Patients will either not drink enough, they'll start vomiting, and then they'll get scared to drink because they'll have some nausea, or some of them, you know, overdo their diet where they'll try and eat a lot like they did before because they don't really understand, even though we give them lots of education, and then they'll vomit, and then they get scared, and then they won't eat or drink, and then they'll, you know, come into the emergency room with these non-specific, you know, malaise symptoms. Severe prolonged vomiting can lead to nutritional deficiencies. Sometimes Wernicke's encephalopathy, B1 deficiency, which I've had a patient who had that. She had, you know, nausea, vomiting, super dehydration. And then, you know, these patients really need to feel normal. They get a couple liters of IV fluid and then they feel pretty good. Then they can go back. We do a trial of PO and they actually do pretty good once they start drinking again. Once they get, you know, feeling good and hydrated, they can tolerate PO. But for some reason, when they're dehydrated and they have this malaise and they feel bad, they just have a lot of trouble tolerating PO, even though surgically there's nothing wrong with the operation itself. But I have had a patient who, you know, had prolonged nausea and vomiting, and then they had a B1 deficiency, and so we had to aggressively supplement B1. But you won't see that in the immediate, you know, 2 weeks post-op, but you may see it a month or two post-op, someone who's had persistent nausea and vomiting and failure to tolerate the diet. Pain is pretty rare. Most of these patients, even a couple hours after the operation, are more or less pain-free. So if there is intense pain, then that's sort of a clue. I usually won't send them out of the hospital with any pain that requires narcotics. I send them home on just Tylenol. So none of my patients get any narcotics to leave the hospital. So if they're coming in and they need, and they have no history of substance abuse, and they need morphine, they need something. So that's an indication, you know, that maybe something has gone wrong, or needs to be further looked at. You know, failure to tolerate PO. This is, you know, I could talk for 2 days on different problems, you know, patients who can't tolerate PO. Basically, you know, as long as the surgery itself is okay, we talked about the malaise and the diet toleration. Dumping syndrome, it's relatively rare, seen in the gastric bypass where they eat too many refined sugars and carbohydrates, and it causes a dumping. You know, they can feel the dumping. They feel very sweaty. But you know, that's just education basically. Hypoglycemia, patients who overuse some of their diabetic medications or haven't been told in a timely manner that, you know, it's time to pull back on their insulin or pull back on their oral hypoglycemics, then, you know, you always have to check their glucose level. And constipation is pretty common. Some of the major post-op complications that are that you guys have seen, some of my patients and may see, are PEs. Identifiable. So the gastric bypass is usually, because it's a prolonged operation, these patients are usually a little bigger and a little sicker. So they do get pulmonary embolism. Same thing as any pulmonary embolism, nothing crazy. It's actually, you know, should be ruled out on any gastric bypass who comes in with tachycardia, especially after you hydrate them. They still have tachycardia, shortness of breath, or, you know, any signs on echo that there's, you know, any right heart strain. And, you know, we've implemented a Lovenox protocol So patients who are BMI 50 or greater go home on a month of Lovenox, or if they have any osteoarthritic problems where they have limited ambulation, no matter what their BMI, send them home on Lovenox. So hopefully we'll be seeing less PEs. Hemorrhage, patients usually, the hemorrhage is usually pretty acute, so I don't think you would see any. The only time you may see a hemorrhage is like a marginal ulcer that's bleeding, or some sort of ulcer that's bleeding. This will be a little later complication, probably more than 2 months out. But same thing, you'll see they'll probably have melena, and they'll have the signs of tachycardia, hypotension. Intussusception of the jejunal jejunostomy, so the distal. It's very hard to assess the distal anastomosis on these patients where you put the two small bowel together. And the reason being, these patients have a very non-specific exam when they're super obese anyway. So the exam is very difficult in these patients, especially fresh post-op. The intussusception usually happens, usually not in the acute phase. I guess it can happen at any phase. I've seen a few. And crampy abdominal pain is basically one of the signs, non-specific crampy abdominal pain. And you do the same thing to rule out that and an internal hernia, which we can talk about here too. So the internal hernia is when we put the small bowel together, we create a hole in the mesentery where the small bowel can slide through and get stuck. So I close this hole. Not everybody does. Some people, I don't know why not everybody does, but and occasionally you can get an internal hernia. Same thing, very non-specific crampy abdominal pain. They can originally tolerate PO, but then after an hour or so, by the time it reaches down there, they have trouble tolerating. So that's something to look out for. A sleeve can have a stricture in it, Again, a stricture is just when we staple across the sleeve, maybe I made it too tight. And usually at the angle of the stomach where it turns towards the pylorus. That is treated, sometimes it's just edema, but I usually don't let patients leave the hospital if they can't tolerate PO. If they're not drinking, then we don't let them leave and we try and figure it out. But sometimes they leave if they can tolerate a little bit, or maybe the nurse doesn't realize that they were spitting up and told me they tolerated it. The patient says they're fine. That happens occasionally too. But that's it's not a surgical emergency, depending on their nutrition. But that can be treated endoscopically with stents. Worst case scenario, we can convert those patients to a gastric bypass, and I just cut above the stricture and bring the small bowel up and convert it into a gastric bypass. I haven't had to do that here yet, so hopefully not. And then abscess, hematoma, those things that are, you guys should be able to, high white count, fever, sepsis sort of picture. And then a leak. So a leak can be an acute leak or late. Most of these patients, if they have a leak from the operating room, are going to be very sick. If obviously any, gross spillage of enteric contents makes anybody sick. So if these patients come to the operating room and they're, out of the operating room, within 6-12 hours, they're going to be sick. So by the time they come home, they're going to be tachycardic and hypotensive, and hopefully we'll figure it out. You can have a late leak, a small leak or contained leak, and patients can be eating even too and have a leak. So, this is something unfortunately, a lot of these presentations to you guys are going to be non-specific abdominal pain, and crampy abdominal pain. Patient feels bad. They don't know what's going on. So, do your best exam, try and localize the pain, and then you think about these, these possibilities. And then the other thing I didn't put on here was a marginal ulcer. So this is a later complication in gastric bypasses where I put the stomach, so the gastrojejunostomy. You can have an ulcer there. And usually it's only patients who have been drinking and smoking after the surgery. We test their nicotine levels before the surgery to make sure they don't smoke. Some patients start smoking, some patients start drinking more, trading one addiction for another occasionally. So these patients, can develop these ulcers. Same thing you'll see in other ulcers. You'll see maybe free air, maybe a contained perforation. Sometimes they bleed, so they might present with a GI bleed. the treatment for those is if it's just pain when they eat, like an ulcer, and there's no perforation, then high dose PPIs we treat them with. If there's an actual perforation, then I'll go in. Sometimes I'll do a gram patch. Sometimes I'll redo the anastomosis. But those if there's any free air contained perforation, then obviously I'll admit those patients. So common imaging. So basically, I mean, you guys know sort of, what imaging to get. The only thing I would add is, CT scan, obviously, and, is a short-term fix. It's hard in a CT scan. You definitely do oral contrast, but, it's hard to actually know how tight, if they read a stricture, a small bowel obstruction where maybe one of the anastomosis has had edema and, or maybe there's an operative error and the anastomosis is too tight, that can be easily seen in the CT scan. You'll just see the contrast, the oral contrast stop. Internal hernias can be suggested on a CT scan. Sometimes they're kind of hard to see, but if you have a patient who has this consistent crampy abdominal pain, failure to tolerate PO, we try and figure out what's wrong. The CT scan shows maybe some swirling, but it's hard to tell because I've twisted everything up anyway with the original operation. Then these patients, usually I'll take to the operating room and put a camera in just to take a look and see what's going on, So, and the only other thing that I'm using more and more, and I love because it gives you a dynamic look, is fluoroscopy. So patients who you think might have a stricture of the sleeve or a tightness in one of the anastomosis, or maybe even an internal hernia, the fluoroscopy upper GI with a small bowel fall through is wonderful because we can watch the contrast go. We can see the functionality of the small intestines, which gives me a much better view. And at Downstate, Dr. Samin, he started the the fluoroscopy with some of the first bariatric surgeons who started doing bariatric surgery. So he's excellent in his interpretation. He's helped me out hundreds of times. So anytime we can get fluoroscopy, if there's some sort of structural problem we're thinking of, it is really great. But that's when he's available during business hours. So it's kind of tough all the time to get that. But a CAT scan in the meantime is good. If patient comes in and, it looks like they're just dehydrated, you give them some fluids, their abdominal exam is fine, and then, lead or two of fluids, they feel better and they tolerate PO, there's no reason to get anything. They can go home, and see me in the office. And that's about it. And the other thing is, we just wanted to, to talk about, treating these patients, which I know all of you do, but, one thing we're mandated here is to, talk about compassionate care for the bariatric patients. A lot of these patients, the more I do it, obesity has multi-factors as far as poverty, nutrition, education, and genetics as well. And these patients many of them have tried to lose weight with fad diets and, stuff they read on the internet. Their education level might be, off or less than, ideal. So, it's just failure after failure. So treating them with respect and trying to support them is always encouraged. Does anybody have any questions? Anybody from the ER have any questions? I can't hear you. Oh, let me unmute you.
Can you hear me?
Yes. Yeah.
Okay. My question is more so, usually we get you guys involved when we have these patients come into the emergency department.
Yeah.
Which thank you guys for coming down to see them all the time. You guys are great. My question is more so, let's say the imaging is negative and it seems like they're just not tolerating their phase of diet. And then we're in a setting where we may not have access to a bariatric surgeon. Like, what's our go-to algorithm of down titrating them to a different bariatric stage of diet? For how long?
Right.
On that.
So that's actually a really great point. So some patients, we give them those stages to progress, and many patients don't progress exactly 2 weeks, every 2 weeks to the next stage of diet. Like, for example, and some patients for the sleeve gastrectomy, I've had patients who we get fluoroscopy, the surgery is perfect. Their body just doesn't react good to, having the sleeve, it happens occasionally that they just don't tolerate it very well. So, and some patients need to be on an almost liquid diet for 3 months before, and then they'll eventually get better and their body will adapt. So if someone's, within the first, 3 to 6 months and they're having trouble tolerating PO, you hydrate them, you get a CAT scan, it looks fine. You're in an emergency room that doesn't have access to a bariatric surgeon. Your general surgeon says, no, thank you. That scares the shit out of me. I don't want to do it. So if you downgrade them you can always downgrade them to a liquid diet. There's zero harm. You tell them supplement a meal with a protein shake and maybe some soft yogurt if they can tolerate that. And that's enough for a week or two until they can get to see a bariatric surgeon. So that's a good thing. If you're in somewhere and then, you hydrate them, they can't tolerate, a burger, but they can tolerate it's a protein shake and they seem okay, vital signs, CAT scans negative, then send them out with follow-up. That's completely fine. Yeah. Yep. Downgrading them that's a great question. Yeah.
Any other questions, comments? Oh, in the chat, let's see.
Oh, I haven't seen the chat. I don't know if I can.
I can tell you. So one of our residents asked a question, can we refer patients directly from the ED if they meet criteria? I'm assuming for bariatric surgery. Also for
Yes.
the downstate, what's the best way to refer?
Yeah, so the best way to refer is to put in a consult for bariatric surgery. And we'll get that in Epic, an e-consult. If you're from downstate and you want to refer, you can send me an email. It's Morin at nychhc.org. So I had a bunch of, I think I forgot to include our contact information. But I did have a bunch of sheets with our contact information. I thought it was going to be in person. So, but if you just put a consult, then worst case scenario, you can put a consult for general surgery with my name on it and we'll figure it out,
Okay, perfect.
Or referral, sorry. Yeah.
Sophia, can I ask a question?
Yep. Or Stephanie.
Sorry. So if a patient comes in and they sort of have inability to tolerate PO, but they look relatively well, not dehydrated, have a soft abdomen, would you guys prefer to be involved early on prior to getting any advanced imaging?
Yeah, so, obviously consult surgery, if a patient comes in and they can't tolerate PO and they have a history of bariatric surgery, definitely consult us, early. We're working on a protocol for observation right now with Dr. Brewster, where, patients who are, it looks like they're just dehydrated. They're going to go to observation for, 8 hours, 24 hours, and then we'll see if they tolerate. If you have a patient who you think is dehydrated, CAT scan is normal, you palpate their abdomen, it's normal, and you hydrate them, they feel better, but they still can't tolerate PO, then that patient needs to be admitted and we got to figure out what's going on, So, and, with usually fluoroscopy is the best, if you get a CAT scan that looks normal and the patient still can't tolerate PO and you hydrated them, then a functional study is what we need next, fluoroscopy. And then if that doesn't show us anything, they still can't tolerate PO, then I'll do an endoscopy and maybe a diagnostic laparoscopy or something like that. Yeah.
And then we just had one more question in the chat. I guess, do patients generally know what type of bariatric surgery they have and if they're coming from a different institution as well, just so we have an idea of what complications based on that?
No, a lot of them don't. I mean, the sleeve is really easy to understand. So a lot of them, understand they get the sleeve. I mean, a lot of them understand that they get the sleeve and the bypass, but I wouldn't I wouldn't hang it 100% on what the patient's history. A lot of them will say one thing and, I do another. For instance, like I have patients who need revision, they gain weight and they say they have one surgery. And then I always get fluoroscopy to find out what surgery they had. And it's always something different. So, just to see what they had going on in there. So yeah, the sleeve and the bypass, if they're pretty fresh post-op, usually they're right. But especially if they're a year or so out, sometimes they go, oh, I think I got the bypass, but it turns out the sleeve or vice versa. Yeah.
Okay. And the
CAT scan's usually pretty good at telling. Not always though, surprisingly, but usually, yeah.
And then the last question we have is, what's the timeline for getting into clinic, just generally?
Yeah, right now I'm booked for like 2 months in clinic, but we're trying to open up our template and get more time in clinic, you know. So as we grow, we've been here about a year. You know, we've been operating for a year, but we've been here about a year and a half developing the program. So we're growing. We just keep getting more and more patients, and we're doing well. So the busier we get, the more we open up. So
Awesome. And I think that was it. Let me just make sure. Yep. Awesome. Oh, sorry. We have one more question in-house here.
Sure.
It's a protocol for the internal creator. It's not saying that it doesn't often show up on CAT scan. So as far as our threshold for taking consultation when you guys are the
It's just in terms of, you're saying that you can't see it on. Okay.
with abdominal pain, regardless of imaging, radiation or.
Okay. So the question, I didn't know if you heard that, Dr. Morin.
No.
So the question was essentially that CT is generally, it's been told not to be as reliable in picking up internal hernias.
It's not. Yeah.
So the question was more so, what's the threshold for just calling you guys early on, even before imaging, if they're having abdominal pain and symptoms, right?
Yeah. Very, very low threshold. Calls right away, especially if they come in and they're within a year and they have abdominal pain, even, you know, within 2 years, it doesn't matter. You know, if they have abdominal pain, yeah, call us right away. You know, whether we'll offer anything, you know, or not, but, you know, we can, you know, agree with the CAT scan, or if, you know, I mean, occasionally if patient's not tolerating PO, they have abdominal pain and it's, you know, 10 o'clock at night, then I'll admit them to my service and get a fluoroscopy in the morning and see what happens, you know? So it's not, you know, very low threshold. I take care of these patients as best I can, you know? So, yeah, low threshold. Yeah.
Awesome. Okay. All right. I think that was it. Thank you so much, Dr. Morin. That was extremely helpful.
Okay, great. Thank you guys so much. It was great talking to you.
All right, you too.